as consultants hired by the executive leadership team for the Greater Los Angeles Valley Children's Center, we are tasked with finding a successful strategy that will help improve the financial and operational status of GLAVCC and to ensure the future successes of the organization. So with that, I'd like to start the presentation. Here's the agenda for today's presentation. The Greater Los Angeles Valley Children's Center is located in Riverside, California, in a region better known as the Inland Empire region. GLAVCC is a 176-bed, not-for-profit, standalone pediatric hospital and has a relationship with an IPA that has over 276 pediatric specialists on staff. So as we enter into an age of healthcare reform, children's hospitals face a specific set of challenges. With Medicaid expansion, they're seeing a higher percentage of Medicaid individuals in children's hospital and consequently a lower percentage of commercially insured patients. Furthermore, Medicaid reimbursement is being scaled back. GLAVCC is not exempt from any of these challenges and has many internal issues as well. They have a high labor and supply cost, which is leading to a negative operating margin, and they've lost $6 million since 2010. They also, from an operational standpoint, have a high readmission rate, and for the acuity of cases they have a high average length of stay. So at this critical juncture, it is imperative that GLAVCC acts efficiently and effectively to really save this hospital. Now, before we get into the specifics on how to tackle the issues of GLAVCC, we need to re-examine the mission, vision, and values of the organization. Because quite frankly, all strategic decisions need to be centered around the mission, vision, and values. So the mission is simply to improve the health of our children through treatment, collaboration, and innovation in our quest to be the pediatric hospital of choice in the Riverside area and grounded in our core qualities of quality, community, and accountability. So taking a look at the Riverside area, Riverside County is the 5th fastest growing county in the United States. Between 2000 and 2010, the population grew 44%, and for every 32,000 births, there was 14,000 deaths. So the population is rising tremendously, and it is getting younger. There's also a disproportionate amount of underserved individuals in the counties, in this Inland Empire region. So as you can see right here, in the Riverside and San Bernardino County, there's 630,000 Medicaid patients, and this is prior to Medicaid expansion. Therefore, we anticipate seeing this number rise. And also, according to the UCLA Center for Health Policy Research, the San Bernardino and Riverside counties have the highest percentage of uninsured children in California. Therefore, it's safe to say this is a fairly underserved population. So now let's take a look at the access to pediatric care in the Southern California region. There's some areas here in Los Angeles and Orange County that have greater access. But if we looked at the diminished and depleted market, that is more in the Inland Empire region. So what are we seeing here? We're seeing a huge percentage of Medicaid individuals, a huge growth in the population, and limited access to specialty pediatric care. So with that being said, we as consultants feel that GLAVCC should adopt a value-based care strategy, leveraging the current partnerships they have with the IPA and to target publicly covered individuals. So what do I mean by value-based care? Simply put, it's better healthcare outcomes for every dollar spent, doing more with less, and having quality as the driving factor here. And this is directly aligned with what's happening on a national front with the Affordable Care Act and what's happening at a local level in California, which is evidenced by the Inland Empire Health Plan, which is the largest Medicaid managed care organization in California that already has established pay-for-performance metrics that incentivize and reward quality. So by leveraging a value-based care strategy, GLAVCC can meet these metrics, get more pay-for-performance reimbursement, have more accountability, and drive quality for better patient outcomes. So the first step that needs to be done, a very integral step, is to really strengthen the relationship between the hospital and its physicians, because the physicians are the strongest asset of the hospital. And now, because California state law prohibits direct employment of physicians by the hospital, we suggest GLAVCC do the next best thing and create a clinically integrated physician foundation, which we'll simply call the GLAV Foundation. This is a 501c3 entity that's physician-driven and maintains physician autonomy. So they can do what they do best, and that's take care of the children. But at the same time, there will be accountability and investment from the hospital as well for clinical integration and for contract management. For contract management, the physicians and the foundation and the hospital can leverage their partnership and the fact they have a special niche in the community with especially pediatric care to get favorable contract terms from Medicaid payers and from commercial payers. And most importantly is the clinical integration piece, that the investment from the hospital will get the physician's offices up to the second stage of meaningful use, not only to get more reimbursement from the HITECH Act, but also to have better clinical interoperability, which drives more transparency in data, driving accountability, and of course, quality as the backbone of this model. So with that, I'd like to hand it off to Tamaria, who's going to talk about what GLAVCC needs to do operationally in order to achieve our desired results.
So Sid has just detailed the value that the Children's Center offers as one of the only children's hospitals in Riverside with an extensive specialty pediatric network. However, we argue that the real value proposition of the Children's Center lies in its focus on community. Now, in order to actualize this value proposition, GLAVCC has to change the way it views itself, its market, and most importantly, its patients. So where does this change begin? It begins with the community of care. I want to take this moment to specifically focus on our team's key findings and recommendations. First, we identified issues around access points. More patients are accessing care through the ED than through the ambulatory care center. We recommend 3 operational initiatives that will focus on routing patients to the appropriate levels of care. Next, we have an expanding Medicaid population with complex conditions. We recommend a care management model that will focus on quality, coordinated, comprehensive care. Now, the next few issues we found were more internal. Supply expenses are high, but by joining NACRI, a National Association for Children's Hospitals, GLAVCC can cut its supply expenses by leveraging existing GPO with novation. Finally, as with all hospitals, labor is a costly but necessary expense. GLAVCC can cut its labor costs by trimming its contract labor, flexing staff based on volume, while simultaneously investing in resources to meet its strategic needs. Now, I want to take a step back because this is not just about GLAVCC and its survival. It's about how you care for patients. So let's view the changes that we recommend through the patient's eyes. First, we'll begin with Manny. Manny's been experiencing severe abdominal pain. His parents don't have a PCP, so they take him to the ED. After Manny is seen by a physician, his family is greeted by an ED health educator who informs the family about proper diet and nutrition and helps his family schedule an appointment with a GI specialist in the ambulatory care center. Next, we have Amani. Amani has been experiencing a persistent ear infection for the last few days. She comes from a working family, and her parents also don't have a PCP. They don't want to take Amani to the ED, where she'll probably be waiting for hours, and the only urgent care center that they know of closes at 5 p.m. So what do? They call 1-800-KID-CARE, an ED hotline that triages patients over the phone and routes them to the appropriate level of care. In Amani's case, it's a trip to the ambulatory care center, which has extended its hours to 9 p.m. to be more conducive to working families. So what just happened here? In Manny's case, we intervened via an ED health educator. Not only did his family receive an education about proper diet and nutrition, they were also educated about another access point, the ambulatory care center. Now in Amani's case, we intervened via the ED hotline. Instead of having a patient in the ED who really didn't need to be there, she was routed to the appropriate level of care. And in doing so, we're able to reduce utilization of the ED and shift costly resources elsewhere. Now, the cases that I presented to you so far have mostly been episodic, but GLAVCC's greatest challenge and perhaps its greatest opportunity lies in how it cares for the population that it already has, the Medicaid population. So what does this population look like? Well, they might look like Andre. Andre was born with a congenital heart defect. He requires a lot of special attention, and he's usually in and out of the hospital. Lately, Andre has been suffering from depression. So how do you care for Andre? The Children's Center will care for Andre with a health home implemented through Inland Empire Health Plan, one of the highest ranked Medicaid plans in California for quality. A health home is outlined and funded by the ACA. It's patient-centered, meaning it focuses on caring for these complex patients through team-based care and real-time data exchange. It also puts dollars on the table if these physicians can care for this complex patient effectively. So this emphasis on quality really fits in perfectly with GLAVCC's value-based care strategy. And that's how the hospital would care for Riverside. Now, as we move more people to the outpatient setting, there's going to be a need to fill those inpatient beds. So strategic outreach to the greater Inland Empire will help fill that need. We recommend branding GLAV Foundation physicians as champions of pediatric care and organizing CME events in East Riverside. Not only does this increase the brand worth of the foundation, but it also positions GLAV as a community resource focused on collaboration, not competition. Now, as you build these relationships, it's going to be necessary to make the referral process quick and intuitive for your potential partners. So you'll need to develop an online referral toolkit on your website with all the necessary maps, phone numbers, and referral forms. It will also be necessary to exclusively contract with Simmons Ambulance for interfacility transports, as long as they can get the patients between hospitals quickly and safely. This is especially important for establishing a continuum of care, meaning that we're going to communicate with those home hospitals so that we can establish a continuum of care around pediatric to home care and pediatric to adult care. And now Kelsey will explain how these operational initiatives will help support the Children's Center financially.
I'd like to start by examining GLAVCC's financials in relation to other standalone pediatric hospitals in the Southern California market. We believe in order to understand where the Children's Center is and accurately project where the Children's Center is going to be, that the hospital cannot be examined in isolation. We also strongly recommend that the leadership committee keep in mind that no margin means no mission. If the Children's Center cannot get out of the red, they will not be able to remain financially viable, keep their doors open, and continue to serve the complex needs of the children in Riverside. Now, my colleague Tamaria has already told you how we're going to cut expenses, we're going to flex staffing, establish a GPO, and we're going to shift people into the outpatient setting to increase those number of visits. But what are we going to do about the inpatient side? I'd like to direct your attention to the slide here and point out the staffed beds of GLAVCC. As you'll see, the Children's Center is about 70 to 75% of the size of these other organizations, and this ratio transfers over to inpatient admissions as well, which is about 70% of these other organizations. However, where we see the divergence is when you examine inpatient revenue. Inpatient revenue is only about 16% of these other organizations. So there's 70% of the beds, 70% of the admissions, but only 16% of the revenues. So what's going on here? We looked at average revenue per admission. I'd like to direct your attention to the top row here. And you'll see that GLAVCC is about $18,000, while these other organizations are in the 50s and 70s. Now, these averages are based on gross patient revenue, so what is being charged per case. And charges are generally based on acuity. A sicker patient will need more services, will have higher charges. So we are assuming that GLAV's patients are lower acuity compared to the rest of the market. Thus, it is critical that we establish this referral stream that my colleague Tamaria talked about so that we can brand our physicians as pediatric specialists, get these acute cases to come to our hospital, get these community hospitals to refer their complex cases to us, so that we can raise this average revenue per admission and help the operating margin get out of the red. However, have to remember that APR DRGs are coming. So we wanted to reach out to the main Medicaid managed care provider and see how these DRGs were really going to affect our organization. They actually informed us that contracted hospitals are going to continue to be reimbursed on a per diem basis, and that non-contracted hospitals are going to be the ones they switch over to APR DRGs. Thus, since the Children's Center is a contracted hospital with the main Medicaid managed care provider, we are assuming that the transition to APR DRGs will not affect the Children's Center financially that much. So with that in mind, we have to look at some other aspects of the financials, however. The contractual deductions were 30% over budget for FY 2012. So we advocate that the Children's Center hire a director of managed care contracts to better understand these contracts, and also to negotiate more effective contracts that align with our value-based care model, which would mean they include pay-for-performance clauses and shared savings clauses. Additionally, we advocate that they adopt an alternative quality contract with their commercial payers. This is currently what Boston Children's Hospital is using, and it is a contract that rewards quality over quantity. So it's not necessarily asking for a rate increase, but it's asking that the physicians in hospital be rewarded when they keep their patients healthy and manage chronic conditions effectively. And this focus on quality and value-based care will translate over to cutting expenses as well. Value-based care will improve quality and reduce waste, which will also help cut these supply expenses and operating expenses. There are other considerations we have to incorporate into the budget as well, however. There are a lot of changes on the national and state level. Nationally, in 2014, we're going to see Medicaid expansion and opening of the healthcare exchanges, covered California. That's anticipated to increase revenues by about 8% and about 6.2% every year thereafter until 2021. And this also includes a healthcare inflation rate of 2.41%. Also, DSH payments will be reduced by 75%. We analyzed what other pediatric hospitals in the market were receiving in terms of DSH payments, and we estimate that's going to be an $8 million reduction for the Children's Center. Finally, there'll be more insured individuals, so we're going to see a reduction of 36% in uncompensated care. At the state level, as you know, the CHIP program, the Healthy Families Program, is being absorbed into the Medi-Cal program. So these children are going to be reimbursed now at Medi-Cal rates, which are 15% less than the Healthy Families rates. So we're anticipating to see a reduction of this in inpatient and outpatient revenues. And finally, perhaps most importantly, Medi-Cal is cutting its rates by up to 10%. Now, it will most likely be less for pediatric hospitals, especially those that serve a high percentage of Medi-Cal patients, but we kept this 10% reduction in our budget in order to keep our estimations conservative. And at the operational level, my colleagues have told you some strategic and operational initiatives that we advocate adopting, and those are going to require some funding. We're going to have new staff for those. But additionally, most importantly, I would like to point out, we're going to have to hire some performance management staff. If we're advocating a value-based care model, we really need to track quality, look at the data to see what targets physicians are hitting, provide them with report cards so they can see how they're hitting these quality metrics, and also to see what incentive dollars they're missing out of. Along with that, we advocate hiring a physician relations director to be a liaison between the foundation and the hospital, and to educate these physicians on what the value-based care model is, what the values are of the hospital, and how they can reach their metrics and their goals. Also importantly, I'd like to point out this expense reduction here. We kept it at 10% for the GPO, though it could go up to 18%, and we kept it here at 10% to keep our financial projections conservative. And also, we're going to see an expense reduction from uncompensated care of about 2.15%. So all these things considered, what is the Children's Center's financial outlook going to be in the coming years? We've made projections through FY 2017, and I'd like to direct your attention first to the average length of stay up here. Might seem strange that it's going up. First, I'd like to point out it's only going up slightly by about 0.7. And as I told you, GLAVCC has lower acuity patients right now, so a 5.1 length of stay is simply too high for low acuity patients. So our quality metrics are going to drive that length of stay down for those patients, but we're also bringing in higher acuity patients, more complex patients from our referring physicians, so that's going to drive the length of stay up. So on average, we're projecting that those two will level each other out, and we're going to see a length of stay of about 5.8 by 2017, which is actually the average in the market right now for hospitals seeing a mixture of low acuity and high acuity. Readmission rates are going to go down as we improve quality, and we're also going to see ED encounters go down as we're shifting people out of the ED and into the ambulatory care center. Now, most importantly, GLAVCC we are projecting will be out of the red by 2015 and will maintain a strong operating margin through FY 2017. And the main driver of all this is, considering the assumptions I previously discussed, is that inpatient revenue is going to increase slightly. We're projecting a volume increase by establishing this referral stream, and we're also anticipating an average revenue increase per patient by bringing in higher acute patients. So taking all these considerations together, we strongly believe that the Children's Center can reach this 3.9% operating margin in 2017, remain financially viable, remain strong, keep their doors open, and continue to serve the complex needs of the Riverside community and beyond. With that, I'd like to pass it to my colleague Sid to conclude the presentation.
Thank you, Kelsey. So I'd like to conclude this presentation by reiterating the fact that if GLAVCC was to close its doors, the children of the Inland Empire region would have limited access to specialty pediatric care. There is a need in the community, and GLAVCC can fill that need. With that being said, we feel that if GLAVCC leverages their physician relationship and adopts a value-based care strategy, they can get themselves out of the red and meet the comprehensive health needs of the Mannies, the Imanis, and the Andres of the community. So with that, I'd like to open it up for questions.
Before Ms. Prigmore gets into the finances, as the physician in the group, you mentioned some interesting things about the foundation, which sounded to me like maybe a virtual practice ownership, because you're getting some of the benefits, but not violating the California law. And you also mentioned having them do ground rounds and do more work in the community. What strategies are you thinking of to influence that physician behavior and to form this foundation and getting them to buy in?
Sure, that's a great question. And as I've mentioned, it is a physician-driven organization. So really, like it means is that it is physician-driven, and so it's really empowering the physicians to use their specialty pediatric care to reach out to the community. But at the same time, with Affordable Care Act, there's going to be a lot of administrative challenges. And as independent physicians, that's difficult to take on in their independent offices. So with the infrastructure investment by the hospital, they can really help out the physicians to do what they do best, and that's take care of the children. And at the same time, you can really leverage the fact that they are a strong organization to really disseminate their specialty expertise in the community.
Thank you.
I have a question. On the 1-800-KID care, how is that going to be funded? Did you put that in your financials in staffing the 1-800-KID care?
Yes, absolutely. So we want to get the 1-800-KID care, the ED hotline, off the ground immediately. So we're going to be hiring 6 experienced telephone triage nurses to handle that. And it'll be open from 4 to 12 a.m. weekdays and 24 hours on the weekends. And we base those hours based on what time of day parents typically bring their children to the ED, which is usually around the evening time on weekends and especially during weekends.
And last to that, so you're going to make up for those expenses, how? And then do you anticipate with the decreased potential volume in your ED services, how are you going to backfill that?
Well, we're shifting the patients that would typically be coming to the ED to our ambulatory care center. We know that the majority of our patients are accessing care through the ED, but some of those cases are non-emergent cases. And the care for those patients can typically be handled in that ambulatory care center.
It is revenue, so how would you backfill that, even with that shift? You thought about that?
Oh, so the strategic outreach to the greater Inland Empire will help fill the need to fill our inpatient beds.
And to follow along that, we really have to market this hotline and the changes that are going on in our hospital as well. So that's why we've budgeted for that there. Because as we're shifting people out of the ambulatory care center, we still want people coming into the ED that belong there. So when they know that we're making these changes to the hospital, that this is a point of access, they'll bring their children there. So we really have to change sort of the entire environment around GLAVCC and let the community know that we are there. Because there's a large underserved population. So if they know that we are a resource they can come to, that will help backfill the people who are moving out of the ED already, in addition to reaching out to those physicians, letting them know we have the pediatric subspecialists that they don't have. They can reach out to us to take care of those complex cases. And this was incorporated into the budget, so it's accounted for in our expenses. And since we're reducing contract labor costs about double of staff labor. So once we cut some of that, we'll have funds available to hire these new staff that we're going to be here.
Let me ask a question about the health home. You mentioned that there's a Medicaid managed care provider. Are these patients that are already enrolled and the managed care company is going to initiate the health home, or are they going to newly enroll patients into the managed care organization? I didn't quite get that.
So this is specifically for the Medicaid patients, the
Right.
health home is. It's a Medicaid program
Right.
that is outlined and funded by ACA. So the funds will actually be distributed from the federal government to the Medicaid plans who choose to participate in the health home.
Right, but how does a patient get into the Medicaid plan? Are these patients that are already in the plan?
They're already in the plan.
Okay. all
And
right.
we enroll new ones as we see fit in terms of their conditions.
All
If they have 2 or more chronic conditions, they can enroll, or if they have 1 and they're susceptible to be at risk for another
So
one.
your strategy here is that the managed care organization is going to initiate this, and how are you going to get them to initiate that?
Sure. We actually have to approach them and say, we'd like to establish this health home because the federal government gives Inland Empire the $500,000 funds, and they distribute it out to the community. So currently in Riverside, there are 13 clinics that are trying to establish this model, but they don't have the patient volume that we have and as complex of cases because they're simply just clinics. So we would have to approach them and say, we want to start this health home, show them that we have these complex patients, the ones that can fill this health home, and we also have the staff that can manage it. We're also hiring chronic disease managers. We've budgeted to have a few RNs, nurses, health educators. So we've incorporated some new staff for that health home into our budget to make sure we can care for those children.
I'm glad you spoke about your additional staff.
Yes.
So
I'm going to switch to that slide while you're asking questions.
Yes,
so I can
could
show
you please? Can you walk me through slide 26 and your, I think it's, it may be your appendix, it's slide 61 to us. Okay, there it is. So can you walk me through the comparison between 26 to what you have on the screen there? You have a 1.3 on slide 26. You have an indication that it's a $1.3 million additional expense.
Mm-hmm.
Where is that on that slide?
Sure. I'll let you go, sir.
Sure. So the 1.3, we're also incorporating the investment we need to make in the physician foundation as well for the administrative infrastructure for that, which includes the chief administrator officer and data analysts. If you could point to the slide where there's
Also a physician relations director to be a liaison between the foundation and the hospital.
So yeah, so that discrepancy right there, so you can see it right there. And the physician's relations director, around that 200,000 is right there with the investment in the physician foundation.
And then can you walk me through how you determine these salaries for the physicians?
Sure. We looked at baseline salaries in Riverside, actually, and we took the expected inflation rate for healthcare employees. That was that 2.41% I showed you on the assumption slide. That's what it is projected to be in 2014 and beyond. It should be around that. So the base salary is currently what these positions in Riverside in the healthcare setting are getting paid. And then we applied the inflation rate to it. And we also have to incorporate fringe benefits, which is typically about 25% added onto salaries.
So I thought your financial analysis was quite interesting and raised some good questions. You're making the assumption that and I thought it was a great analysis around the ratio of only 16% of the revenue, whereas the others are 70% or should have been about 70% of the revenue compared to their peers. Mm-hmm. My question is, why would you assume that it's the acuity of the patients? Do you think maybe you have a charge capture issue?
Sure. Well, we actually reached out to a financial advisor at a hospital to discuss this because it is a little bit puzzling to see that drastic of a difference. And when you look at charge master rates around the Southern California region, they're pretty level. So we looked into seeing if it was maybe that they just weren't charging the correct amount or charging as much as these other organizations. That's a very highly unlikely probability, and that would be something that if the hospital were losing money since 2010, it was $6 million, or they would have looked at that. And so we really believed that the cause of that was that the patients were lower acuity, especially since you have these competing hospitals over on the West Coast who have specialists as well. It seems like a lot of the acute patients were going over there or just trying to get services by their primary care physicians. So that really seemed like the most likely case, especially since the numbers were there. They had the patients, they had the specialist. It just seemed like the services that they were providing weren't racking up the charges that these other organizations were seeing.
Thank you.
I had two questions that I thought of, and this is in relationship to the your utilization of Manny. So one would be Manny is described as being referred to an appointment is scheduled for him with the GI specialist. So my first question would be, how do you know he keeps that appointment? So that would be one. And my second question would be, if there's any barriers to him getting to that appointment, how would you address those?
Okay, that's a great question. So once Manny is in the ED, that's going to be documented as a patient encounter in the EMR. His care management plan will also be documented. So if he doesn't show up to that appointment, then his no-show will actually be documented in the EMR as well. And to answer your second question, if you could repeat it, please.
The second component was if there's any barrier to Manny actually getting to that appointment. When you described him, I would just say it was a family in need where the resources, maybe there's transportation issues. Just curious as to how, if there was a barrier to him getting to that appointment, had you had any thoughts around addressing that?
Actually, yeah, that is great. So the first thing that we did with the ambulatory care center is that we extended the hours to 9 p.m. and it's also going to be having some weekend hours as well. Now, Manny has transportation issues. We're also planning to establish relationships with community-based organizations in Riverside. And if you can see here, the Child Health and Disability Prevention Organization, it can assist families with transport to their diagnostic and treatment services.